good evening, everybody. I'm very happy to be between you today, and I hope you get benefits from these regular lectures. Today's lecture is the second lecture about the Petrous bone imaging. We gave in the first lecture just brief topics in the external and the middle ear pathology, and today I will continue the inner ear, and I hope you get benefits from this lecture. I think today is very important, and so try to pay attention as you can. I will start with some anatomy imaging of the temporal bone and the internal auditory canal. CT and the MRI are complementary in evaluation of temporal bone and the internal auditory canals. The advantage of the CT best evaluates the bone. CT, bone, MRI, soft tissue, nerves, including nerves, muscles, fluid containing structures. Best evaluation, the CT is the best evaluates bony morphology, otic capsule, including development and the partitions, for which is important because in defect in the partition will be a reason for congenital anomalies. Readily identifies regions of abnormal lucency or mineralization. Best visualized external auditory canal, middle ear structures in setting of conductive hearing loss. Advantages of the MRI evaluation of the membranous labyrinth, abnormal enhancement, and assessment of the cranial nerve, special cranial nerve number 7. Here it is the anatomy for the inner ear structures. The bony labyrinth is whole of this bone, and the membranous labyrinth is a fluid, the low density structure inside the bony labyrinth. That we have here, it is a cochlea, the modulus, which is dense structure and the very important have very important role in the partition of the cochlea. We have here the basal turn of the cochlea, and here the middle turn. Next is the apex, the apical turn, and the middle turn, and there is basal turn of the cochlea. We have the normal 2.5 turns of in the normal cochlea with 2.5 nerve, and you kindly remember this shape and this appearance very well because it will have we will use this anatomy again late in the current lecture. Here, next is the vestibule and the semicircular canals. We have posterior, lateral, and superior semicircular canal. Here is a vestibule. Here it is the semicircular canals, and here it is the vestibular aqueduct. And here is the superior semicircular canal. This is lateral semicircular canal. There is a connection between the vestibule and the vestibule and semicircular canal and the cochlea. Here is a connection between both of them and the cochlea, and here is the vestibule, and here is it is the 3D MRI, and it is superior semicircular canal, lateral semicircular canal, posterior semicircular canal. So move on to the cochlea and the other images for the anatomy of the cochlea. It is the when I see the steps, so the structure adjacent to the steps and intimately linked to the vestibule is the oval window. Very important structure. Vestibule related to the equilibrium and the cochlea related to the hearing. Oval window is related to the vestibule and the semicircular canal. And don't forget, this anatomical structure is very important. Foot of stapes or base of stapes. At the foot of stapes, there is oval window. Okay. Next is the rounded window, which is linked and attached and connected to the cochlea, and so it is related to the hearing. Okay. Vestibular aqueduct. This is a normal aqueduct, and the congenital anomalies of the vestibular aqueduct are the most common congenital anomalies of the ear. It is the vestibular aqueduct, and here is the vestibular aqueduct. The next is cochlear aqueduct. In the CT, you can see it just below the internal auditory canal. The level, one level before, one or two cuts below the internal auditory meatus, you will find the cochlear aqueduct. The vestibular aqueduct, there is an important measurement. It is 1.5 millimeter, not more than 1.5 millimeter. It is the inner ear. In the MRI, the nerves, 7 is up, facial nerve, 7 is up, and anterior is the facial nerve, and here it is the posterior is the cochlear nerve, the posterior and inferior is the cochlear nerve, posteriorly the vestibular nerves, superior and the inferior vestibular nerves. First pathology with us is superior semicircular canal dehiscence. All the semicircular canals and the vestibule and the cochlea are liable for dehiscence, but this is the most common and this is the most important. This could be congenital or due to trauma, barotrauma, and also with cholecystoma. So here it is, the superior semicircular canal. You will find defect here in the bone. So this dehiscent superior superior semicircular canal. And here it is also, there is dehiscence here of the semicircular canal. Cochlear dehiscence, forget it. I will say it and forget it, please. Okay. Here is dehiscent modulus. This is an example for cochlear dehiscence. So kindly leave it now. Okay. The voice is not high, is not good. Just can you answer on the chat, please? Okay. So the cochlear dehiscence, enlarged vestibular aqueduct, which is the most common. The cochlear dehiscence, semicircular canal dehiscence, the most common is superior semicircular canal dehiscence. Next is the enlarged vestibular aqueduct, which is normal, A, B, or C. Can I see on the chat, please? Many thanks. Yeah. Okay. Which is normal. Okay, great. Here it is, the vestibular aqueduct, which is widened here, and here in the MRI there is a vestibular aqueduct. This is the most common anomaly in the inner ear. Okay. Other examples, bilateral, because it can happen bilateral, and when it happens bilateral, you may be or you may not be able to differentiate between to call it as abnormality, but kindly you have to know the anatomy of this region very well. This vestibular aqueduct is vestibular aqueduct. The next, can you mention the pathology in the images? I made it easy because this is the images from StatDX, so it is easy now. This is the pathology. This is the abnormality. Can you mention the pathology on the chat, please? No. What is the anatomical structures? What is the anatomical structure here? Great. So what is the pathology? Okay. No worries. No. Who said sclerosis? Yeah, Rania. Yeah, okay. Okay, great. This is otosclerosis. This is misnomer. It is the true name is autospongiosis, because it presents with lucency. In the beginning, it presents with lucency of at the region of the around the oval and round window. Okay, it present with lucency around the oval and the round window, and it is common. It is not uncommon, especially during and after pregnancy. It is not uncommon. More common in females. It is misnomer. Check this is a photo of stapes. This is the oval with the oval window. So there is this bone is lucent compared to this bone. The degree of the ossification has decreased. Then with time, it will develop some calcifications at that region. This is the otosclerosis. The clue: young adult develops gradual chronic conductive hearing loss. Early disease location begins at the anterior margin of the oval window. This is called fistula antifenestrum. The other type is very rare, fistula retrofenestrum. The bone is very important. The bone CT is very important, and the main radiological modality for the assessment. Leucentis, which becomes sclerotic layer. Sclerotic lesions along margins of the oval and round window. In the MRI, during the activity, it shows enhancement. Here it is, the MRI. You can see enhancement at the oval window region, and here it is, the vestibule. Okay? Okay. What is the pathology? Can you mention and say it on the chat, please? I want anatomy and pathology. Start in your mind with the anatomy, and you will find the pathology. Great. Yeah, great. Labyrinthitis ossificans. Suburative inflammation of the labyrinth, and then calcifications and ossifications with time. Can be a complication of infection of the brain, inflammation of the brain, like meningitis. Okay. Labyrinthitis ossificans, profound sensorineural hearing loss. It is the inner ear structure. So sensorineural hearing loss. Okay. Ossific plaques impinge on inner ear fluid spaces. In the T2, loss of fluid signal. In the CT, increased density. In the MRI, loss of the high T2 signal. Calcifications in the cochlea is often considered a contra-indication for cochlear implant. Okay. Here it is, in the CT. What is your impression? What is your impression? This is not high T2. This is a cochlea. This is the cochlea. This is the vestibule. Cochlea, vestibule. What is this? This is calcifications. Okay. Yeah, loss of fluid signal. Yeah. Okay, great. Next. Yeah. What is this? This is a bit difficult. And this is not vestibular aqueduct. Yeah. Okay. It is near to it, but it is not it. This patient has history of tinnitus. I'm asking you. Okay, great. This is high jugular bone. Okay. This is asymptomatic, normal variant. It can present. It is uncommon cause of. It is uncommonly cause of pulsatile tinnitus. In the bone CT, Kefal. This is best in the coronal. Kefal, the portion of the jugular bulb projects to the level of the internal auditory canal at the level of the basal turn of the cochlea. As mentioned, this is a basal turn of the cochlea. Okay. It is MR findings may simulate enhancing lesion posterior to internal auditory canal, more common on the right side. If I ask and the answer on the chat, what is the signal in the T2 sequences? T2 sequence, what should be the signal? what should be the signal of high jugular bulb in T2 sequence? Great. It follows the venous signal everywhere. High T2 signal in any venous structure, not venous malformation, in vein means thrombus. Okay, thank you. Next case, here it is the MRI. You will find here is the nerves, and here it is the basal turn of the cochlea, and here it is the level of the jugular bulb. You can compare it to the other side. It is more common on the right side. Next, yeah, what is the pathology here? It is a bit difficult, odd pathology. Okay, no answers? Okay, this is diverticulum. This is the jugular vein, and this is diverticulum of the jugular vein. Okay, it is not so common. The thumb-like projections, jugular bulb diverticulum. Okay, okay. If what is, just let me describe, give me description. I don't know. I don't want diagnosis. I want description in this case. What is the pathology? What is the abnormality which hits your eyes? I cannot see any messages on the chat, please. So try to say anything. What is the pathology? Okay, no worries, no answers. Okay, okay, great. Okay, great, right. Okay, this deficiency around the cochlea. This is the patient osteogenesis imperfect. Osteogenesis imperfect. Okay, there are other abnormalities for osteogenesis imperfecta, the basilar invagination, Wormian bones, but this is lucency, which will not be sclerotic and will expand with time to involve the aortic capsule. Okay, this is osteogenesis imperfect. Okay, just consider it is not in the 2B, it is in the 2A. Okay, and this is one of the problems, the hearing loss of osteogenesis imperfecta. Okay, and the reasons: inner ear, it is normal progressive aortic capsule demineralization, early band-like very cochlear lucency, and delayed lucent aortic capsule bone, and which enhance on MRI. The ossicles and the mastoid ear cells, there are tendencies to fracture because of fragile bones. The skull base, the cranium, diffuse demineralization, Wormian bones in the skull, the fracture, jugular vein stenosis, large mastoid emissary veins. This is not important for our topic. Okay, it is okay. If I ask what is the pathology, what is the abnormality you see in the current study, the current images? Yeah. Okay, which is more dangerous and more common to be associated with sensory neural hearing loss, transverse or longitudinal? Okay, longitudinal fracture can be associated with sensory neural hearing loss or not? Okay, great, thank you. This is a fracture. The fracture could be transverse or longitudinal. Both of them can be reason for sensory neural hearing loss, but it's more common with the transverse fracture. Pneumolabyrinth, air within the fluid, is one of the signs of labyrinthine involvement. High T1 signal denoting blood in the inner ear. Like here, you will find a comparison between both sides. This high signal, but loss of the signal here denoting hemorrhagic component following trauma. Okay, so here it is. This patient, what is the abnormality? What is your impression from this abnormal finding? What is the structure? What is the name of this structure? And if I tell you this there is enhancement of the labyrinth and the labyrinth, including the cochlea and the vestibule. So what is your impression? Great. It is labyrinthitis. Okay. Labyrinthitis is the acute onset of vertigo. Labyrinth, vertigo. Hearing loss also, but mainly vertigo. In the CT, acute phase is normal, no findings in the CT, unless it becomes chronic and the labyrinthitis ossificans. But in the MRI, either normal or diffuse enhancement of the inner ear fluid spaces. Okay. This structure is aberrant internal carotid artery. The most important point is tubular structure. Unfortunately, if you call it as glomus tympanicum, unfortunately, you may meet the problem in the court. The history is very important because here the history is very important. The clinical examination is very important, and you have to chase this with the referring physician. What you can see from the extent by the otoscope. Can you find highly vascular structure? Take care before calling it glomus tympanicum. Okay, this tubular structure, and don't forget to see this structure, this dilated inferior tympanic canaliculus. Okay, tubular structure, dilated inferior tympanic canaliculus. And if you are skeptical, don't call it glomus tympanicum alone. Say that the possibility of aberrant internal carotid artery still should be concluded in the differential diagnosis. They will do angiogram and they will discover that. Okay, but don't say it glomus tympanicum in your report at all. Okay, and even in the exam, consider aberrant internal carotid artery. Okay. Next case, this difficult case, it is vascular malformation in the inner ear. It is hemangioma. Okay, so it is honeycomb in the CT, honeycomb high density matrix lesion, the most commonly located in the geniculate fossa. It is enhancing geniculate ganglion area lesion, and usually with irregular margins. Next case, before I start it, I have to give you a hint about the anatomy of the facial nerve. Here it is, the intracranial component, labyrinthine component, geniculate component, tympanic component, mastoid component. Okay, intracranial, labyrinthine, geniculate, tympanic, and the mastoid through the stylomastoid form. Okay, so what is the pathology? It is not so difficult. Describe the pathology first, then include neurofibromatosis in your management. Okay, but you have to describe the pathology first. Okay, schwannoma, bilateral schwannoma. Okay, great. So vestibular, it is vestibular schwannoma associated with sensory neural hearing loss, ice cream cone, ice cream on cone. This is the morphology, because you have to search for the intracanalicular components. There is associated widening of borus acousticus. This is the normal. Borus acousticus is the internal opening of the internal auditory meatus. These the acousticus meatus, widening of this is normal. This is not abnormal. This is normal. You have to compare between both of these structures, and it will be widened on the affected side, but sometimes it is on both sides. But so you have to compare between both of them, and if you feel that there is relative asymmetry, you have to mention it, even you cannot see any sizable masses. If you feel that there is some widening, you have to highlight it and mention it and recommend MRI with contrast study, okay? Especially if the patient has a history of hearing loss. In the T2, it is heterogeneous high signal as here, but homogeneous, almost homogeneous enhancement. And don't forget the intracanalicular component, which differentiates it from the meningioma, okay? The common differentiating the other lesion, which could be present here in this region, cerebellopontine angle, is epidermoid cyst. And the epidermoid cyst, with the epidermoid cyst, there will be diffusion restriction, and there is no enhancement. But here in the vestibular schwannoma could be associated with no diffusion restriction. And then this is one of the main differentiating point between both of them in the non-contrast study. In contrast study, homogeneous enhancement of schwannoma, but the epidermoid cyst will not enhance. Okay. It is, what is the pathology? What is the pathology? The chat. What is this structure? What is the anatomical structure here? Two different patients. Great. Yeah. No, not mastoiditis. This enhancement, not T2. This enhancement, not T2. This mastoid component of the facial nerve. Okay, it's facial nerve schwannoma. Okay, this enhancement of the facial nerve. The facial nerve in the temporal bone, we have the component of the facial nerve. 4 component. Geniculate. We mentioned that intracranial, we have the labyrinthine, we have the geniculate, we have the tympanic, then the mastoid. According to every anatomical structure, if there any lesion involving the facial nerve will have the shape which adapt to the surrounding structures. In the geniculate fossa will be ovoid, with a smooth enlargement of the geniculate fossa, with projections into labyrinthine and the anterior tympanic segment of the cranial nerve 7. The tympanic segment pedunculated. In the mastoid segment, it will be tubular with sharp margins, or globular with irregular margins. In the greater superficial petrosal nerve, enlargement of greater superficial petrosal nerve canal in the middle cranial, which present as middle cranial fossa mass. Here it is. If I ask you, what is the abnormality here? Where is the abnormal enhancement? What else? No, not all of them are abnormal. These are normal. Tympanic component, tympanic and geniculate components are normal. Tympanic geniculate are normal. Okay, tympanic geniculate mastoid are normal, but here it is, the inner ear is abnormal. cerebellopontine angle enhancement are abnormal. Okay. Intratemporal facial nerve enhancement, mastoid tympanic and geniculate ganglion segments generally shows contrast enhancement. Contrast enhancement are variable dependent on the technique and the field strength, but normally symmetric bilaterally. Facial nerve within the internal auditory canal should not enhance normally. Okay. Maybe genicular portion of the facial. Okay. Okay. What do you mean, Rania, please? Okay. The next is the Bell's palsy. Bell's palsy is an inflammation of the cranial nerve, early clinical. That you will not find this patient in your clinic unless, or your center or your hospital, unless this patient has been suffering for a long time. Okay, because early this patient go to the ENT consultant will not send this patient to you. Okay, this clinical diagnosis, but he may send this patient to you, and when he send the patient to you, you have to do the protocols you follow the protocols for assessment of the nerves, post enhancement, post contrast, fat suppression with thin cuts, T2 thin cuts, cis sequence or VIBI, post contrast VIBI sequences to assess the nerves. In the Bell's palsy, you will find fundal tuft and the labyrinthine segment, labyrinthine component, which is not allowed to see it enhanced. Show intense asymmetric enhancement. Entire intratemporal cranial nerve may enhance, less frequently intraparotid segment. In the thin T2, a small cranial nerve thickening is common but lacks focal nodularity. Consider this point because we will use this differential later. Imaging with the classic rapid onset of the Bell's palsy requires no imaging in the initial stages. You will not find this patient with the history, with short history. You will find him with long history, relative long history. If a typical Bell's palsy, search for imaging for the underlying lesion. Okay. Here is enhancement of the inner ear component. This is intratympanic, entire intratympanic, but there is no nodularity. There is enhancement, but not nodularity. And you have to compare to the other side. If asymmetry and the involvement of the inner ear of the labyrinthine and the labyrinthine component, this means that abnormal enhancement. Ramsey-Hunt syndrome. It is associated with linear to nodular enhancement of the internal auditory canal fundus. Entire intratemporal enhancement of the intratemporal component of the cranial nerve 7 enhancement is typical for it. Membranous labyrinth enhancement of the membranous labyrinth. In the external ear, you will find asymmetric cutaneous enhancement during the active vesicular stage. In the brainstem, you may find enhancement in the facial canaliculus. Ramsey-Hunt syndrome is very important in the exam. Very important in the exam. And the other name is Toulouse-Hunt syndrome, which is enhancement of the inflammation of the cavernous sinus. Okay, so Ramsey-Hunt, it means the facial nerve. Toulouse-Hunt go more anteriorly into the cavernous sinus. Ramsey-Hunt can involve also the vestibulocochlear nerve. Okay. These examples, because the inflammation and the gathering of inflammatory component can present in the T2 with relative low signal, but the most important, the enhancement. Here it is the entire intratemporal component. Here it is. I will just say some anatomy here. Here should be this labyrinthine component. Okay, and here is the geniculate ganglion, and here it is the tympanic component, and there is greater petrosal nerve. I hope this anatomy is clear. I hope this anatomy is clear. Labyrinthine component, geniculate ganglion, go tympanic component before exiting through the styloid foramen, which will come coronal. This the greater petrosal nerve. Okay, I hope this is clear. Any question? Okay, no, the genicular is normally enhanced, normal enhancement. Okay, okay, I will repeat it. Okay, Ramsey Hunt, you speak Amjad about Ramsey Hunt? Okay, Ramsey Hunt syndrome. It is inflammatory process involve the facial nerve and could involve the vestibulocochlear. Okay, it present with inflammatory component can gather, make solid component, nodular component. In the T2, this could present with low signal, not high signal. But the most important is the enhancement, and the enhancement of the whole intratemporal, whole intratemporal facial nerve is characteristic. And the nodular enhancement, which differentiate it from Bell's palsy. Bell's palsy, there is enhancement, but not nodular enhancement. Okay, and here it is the anatomy. These labyrinthine components, this intracranial, here coming here from this region, the facial nerve, cerebellopontine angle, intracranial, labyrinthine component, geniculate ganglion, and here it is tympanic component, and this is a branch greater petrosal nerve, which one of the connection with the trigeminal nerve, and this is one of the sources of the perineural spread. Okay, I hope this is clear now. Can you confirm, please? Okay. Okay, thank you. The perineural spread, I mentioned it before, but in the exam, don't search for the images. It will not come. It will not come in the 2B unless it is very obvious. It's very obvious. And but in the 2A exam, there is a must question about the perineural spread. The must question is, what is the most common tumor associated with perineural spread? This means adenocystic carcinoma. Adenocystic carcinoma. The other tumor is the mucoepidermoid. I will tell you something. The mucoepidermoid and the adenocystic carcinoma will present on this in the same question in the exam, in the same choice, in the same question as different choices. But kindly choose adenoid cystic. The relationship between both of them, like the inguinal hernia and the femoral hernia. What is the most common to strangulate? Commonly, the femoral, the possibility of strangulation of the femoral hernia is more compared to the inguinal hernia. But because the inguinal hernia is very common compared to the femoral hernia, has high number and the frequency, more frequency to strangulate. This is the same. In the exam, it is adenoid cystic carcinoma. Yeah, mucoepidermoid is very common with mucoepidermoid, but in the exam, it is adenoid cystic carcinoma, where in the salivary gland, parotid gland. Okay, hope it is clear. Okay, normal cochlea. This is the septum, and there is scala tympani and the scala vestibuli. Scala tympani and the scala vestibuli. Have a look for 5 seconds before I move to the next slide. Septum, scala vestibuli, tympani, scala vestibuli. What is your opinion? We mentioned that we have the modulus, bony, dense structure. We have 2.5 turn. So what is the pathology? I would be grateful if you mention on the chat. answers. Okay, no worries. Okay. There is okay, less than 2.5. So what is this? This Mundini. This is a Mundini. Okay. This is 1.5 turn. This septum is not present. It is present only. It is basal turn. Okay. So it is only basal turn, and so it is 1.5 turn, not 2.5 turn. Absent interscalar septum. Interscalar septum between the plumb, middle, and apical turn. Don't mistake osseous spiral lamina for interscalar septum. Smooth external contour. Vestibular aqueduct in the lymphatic sac typically enlarged. Vestibule, normal vestibule. Semicircular canal, normal or mildly plumb anterior limb of the lateral semicircular canal. So it is 1.5 turn. Vestibular aqueduct typically large. The vestibule, normal or large. Semicircular canal is normal. On the other hand, what is this? Vestibular aqueduct dilated, vestibule dilated. So what is this? How many turns in this case? This same, still modulus, 1.5 turn. This is still Mondini, okay? What about this? What's your impression? What's your impression? There is no modulus. This is cochlear incomplete partition. In this case, there is no septum. There is no bony septum at all. No modulus. Amorphous sac. Wide communication between the cochlea and the vestibule. Some external structure dilated, external structure dilated vestibule, horizontal semicircular canal mostacum. External indentation suggesting cochlear turns, plus or minus normal vestibule. Here it is. The cochlear nerve will hypoplastic or absent. The cochlear canal, internal digital canal, normal, could be wide or narrow, absent or absent. Vestibule, horizontal semicircular, usually dilated. Vestibular aqueduct, usually normal. So here, usually, vestibular aqueduct is normal. On the other hand, the previous type 2 Mondini, vestibular aqueduct will be dilated. Vestibule here, usually dilated. There could also be dilated, but not common like here. Okay? The cochlear nerve, hypoplastic or absent. What is the can this patient have cochlear implant or not? Mention on the chat, please. Yeah, true. Great. Okay. Here it is. The vestibular aqueduct is not dilated. There is no turns at all. The vestibule is disfigured or mildly dilated. Okay. So what is this? Compare between both sides. Here it is. There is a cochlea. There is vestibule. There is the labyrinth. Here it is. I cannot find anything. So it is this labyrinthine aplasia. No labyrinth. It is Mitchell deformity. Okay. Mitchell deformity. Okay. The worst deformity. Okay. This is Mitchell aplasia. Is aplasia in the Britain. The British. The finding is typically bilateral, unilateral. In unilateral cases, the other side typically has another form of severe dysplasia. The internal digital canal is absent or atretic. There is no lucency in the location of the otic capsule in the Petrous temporal bone to indicate labyrinthine structures. In the MRI vestibulocochlear nerve, you will not find it. You will not find it. Okay. It is associated with other anomaly in the skull base abnormalities, like this associated with other anomalies because it is related to thalidomide exposure, something which means that there is deformity, there is great marked deformity of this baby. Okay. Before cochlear implants, you do need to do CT and MRI. But what is the role of the CT and what is the rule of the MRI? The role of the CT for aberrant dehiscent facial nerve, okay? Dehiscent jugular bulb, for aberrant carotid artery, for enlarged vestibular aqueduct. MRI for cochlear nerve hypoplasia or aplasia, early stages of labyrinthitis ossificans, early brainstem infarction, and the enlarged endolymphatic sac. Kindly consider these points. You will not assist, you are not requested, even in your clinical life or in practical life, you will not, it is very rare to send to you any patient for cochlear implant assessment, pre-cochlear implant assessment, because this is sent to specialized center, okay? But consider this point, because if you meet, at least if anybody asks you to review case for him or like that, you have the points which you should comment on, okay? In the Petrous apex, it is very important structure, and a lot of pitfalls happen around this region. In the imaging, CT and MRI are complementary to each other in the bone CT to evaluate the Petrous apex, bone expansion or destruction, which can happen, cholecystoma, even cholecystoma can happen in the Petrous apex. And the MRI for lesion tissue analysis, the MRI can help you to characterize the signal and the nature of the signal and give you an appropriate differential diagnosis. Be aware of the confusing high T1 MRI signal in trapped fluid with Petrous apex cholesterol granuloma. It is very important. The high T1 could be proteinaceous content or fat, okay, or marrow. And if you find it, don't call cholesterol granuloma or cholesterol unless you find erosion. When protein content is high, T1 signal may be high. In absence of bony expansion, bony erosion means cholesterol. Bone expansion, cholesterol granuloma. Lesion should be considered trapped fluid. But if there is expansion, this cholesterol granuloma. Okay. Cholesterol granuloma will signal, high T1 signal. What is the signal in fat suppression sequences? Okay. What else? Okay. This is a high signal. Will not the signal will not suppress because it is more hemorrhagic component. Okay. It is, yeah. What's your impression? What is this? Oh. Okay. No. No expansion. There is no expansion. This is normal marrow. This is a marrow. Here, this is a marrow. This is a fat marrow. Okay. Okay. Asymmetric marrow present with asymmetric pneumatization makes contralateral fatty marrow conspicuous in the bone CT non-expansile fat density in the Petrous apex, in the MRI high T1, in the T2 low T1 signal on fat SAT sequences. So these in fat SAT will suppress finally. Okay. Here it is. Yeah. What is it? Okay. Okay. Before I answer, I kindly find the attached feedback form. I would be grateful to you if you give me feedback for these lectures. I kindly read every word. It is something essential for improvement of our lectures quality. Okay, here it is.
Put
You
the
will
link
find
in
here,
again.
okay, here it is. Entrap the fluid. Entrap the fluid in the Petrous apex. Okay, this is entrapped fluid in the Petrous apex. Okay, entrapped as we described. It's a high T2 signal. There is no expansion. High T1, low T1, or high T1 because if it contains proteinaceous content. Here it is. What is the pathology here? Huh? Is T1 is there is expansion. Okay, great. Thank you. Okay. Don't forget high T1, high T2, no suppression. Okay. If there is suppression, it is mirror. If there is no bone expansion, it is trapped fluid. Okay. Here, expansion and no suppression of the signal. Okay. So it is cholesterol granuloma. Next, yeah. What is this? It is just difficult, yeah. Yeah. Can you tell me what is the syndrome, the name of the syndrome associated with it? If there is pain, history of pain, problems, what is the name of the syndrome? Not meningioma. It is not meningioma. It's not typical for meningioma at all. What is the name of the syndrome? Think Gradengo? Gradengo? Okay. Petrous epicitis. Petrous epicitis or apical petrusitis. Okay. This bony destructive changes, trabecular breakdown present, enhancing thick dura. The thickening of the enhancement of the dura is reactive. Okay. Don't forget the history: fever, retroorbital pain, and autoray. Okay. Yeah. Okay. Yeah. Yeah. Okay. Great. So with Gradingo. Okay. What is this? I think the CTU makes it very easy. I wish I think I'm a bit generous in this case because I should show you the MRI only. So what is the crack? What is the problem here? Destruction. Entrapped fluid. There is no expansion. There is no destruction in the entrapped fluid. No expansion. No destruction. And the history. Okay. It is aneurysm. Okay. No. This is not internal carotid artery aneurysm. No, aneurysm. The adhescence would be here, coming here. Okay, coming here. But this is large aneurysm. Okay. Here it is. This is another patient. Okay. Is internal carotid canal expansion. So this aneurysm. This is a fatal mistake in the exam. Okay, fatal mistake. Okay. The calcification in the CT, in the MRI, heterogeneous T1, T2 signal in the MRI is very helpful. Okay. So what is this? Mucosa. Okay. Some expansion, low T1 expansion is also characteristic, and also it is similar to cholesteatoma. Which differentiate between both of them is the diffusion. Mucocele will show no diffusion restriction, and the cholesteatoma will show diffusion restriction. Okay, it is low T1, high T2 with no enhancement. Cholesteatoma enhanced or not? Can you tell me? Cholesteatoma enhanced or not? What else? I need more answers. No enhancement, non-enhanced diffusion restriction, non-dependent if it is in the middle ear. Okay. Take home messages. Know what you expect from CT and MRI. The bone, CT. The bony labyrinth, CT. The congenital anomalies and the modulus, CT. MRI, the nerves, perineural spread, the inflammation, the enhancement in nodular enhancement in Ramsey-Hunt syndrome of the facial nerve, the enhancement non-nodular in Mohammad, not Ahmad. Yeah, Ahmad is the other. Okay. Here it is. Here it is the mucocele. No worries, no worries. Okay. Here it is. This is the mucocele. Okay. Okay. There is no the enhancement non-nodular with long history, Bell's palsy. Okay. Differentiate between the requirements of the assessment of the cochlear implant. Okay. The CT is very good in the jugular bulb. In the dehiscent jugular bulb, the MRI is very good in the schwannoma. CT can assist the widening of the internal auditory meatus, okay? But MRI can assist the lesion and cerebellopontine angle, okay? In the Petrous apex, MRI is very important and very helpful. MRI high T1 can be cholesterol granuloma, but no fat suppression. Can be entrapped fluid with proteinaceous content. There is no expansion like cholesterol granuloma. Can present with MRI, no diffusion restriction, mucocele. With diffusion restriction, it is cholesteatoma. Okay, Petrous epicitis or apical petrusitis. Okay, Petrous apex pitfalls. The MRI is very helpful, very helpful. The marrow, the non-aeration, all of this can be easily solved by the MRI. Aberrant internal carotid artery. You will hear about this patient. You remember this patient in the court. Don't call it glomus tympanicum only. Mention the possibility of aberrant internal carotid artery could not be totally excluded and suggest angiographic study. Okay. How many cochlear turn? Normally 2.5. If less than that, search for the modulus. Present, it is Mondini. Not present, it is type 1. Okay. Comparison between both sides. But sometimes you will find the vestibular aqueduct on both sides dilated. So you have to know the parameter with 1.5 millimeter. Okay. Cranial nerves 7 enhancement. It is tympanic or labyrinthine. If labyrinthine, it is pathology. Tympanic, no. Could be normal, especially if there is no history.